Okay, let's talk about chapter 45, all about fractures. So this is a little joke I just put in here, the vampire getting blood oranges, very funny. And then this is the different types of fractures. So this is represented in your book on page 880, and these are different types of fractures. So you have the avulsion where the tissue or the bone is torn off. Comminuated is like broken in many pieces. Displaced, you can see that the bone has gotten out of alignment. A green stick fracture is in your book, and it's an important thing to know on page 879, and it describes the term green stick fracture has been used to describe the incomplete fractures most commonly seen in children. So in this case, the bone is splintered on one side, but only bent on the other side. So you can see that pretty well in this picture. Then there's an impacted fracture where the upper bone is pushed into the lower bone. And then you've got a longitudinal fracture where it's just lengthwise fracture. The oblique fracture, which is like a slanted fracture, a pathologic fracture where it just breaks on its own, maybe due to osteoporosis. The spiral fracture, it is maybe when someone's turning, they just tear that bone into a spiral. A stress fracture is just from constant use. And then you've got the transverse fracture where it's just straight across. So let's talk about the classification of fractures. So there's the closed or simple fracture, and that's where the bone does not break through the skin. It just breaks inside of the arm or the leg. It just breaks. There is some trauma inside, but it's not too bad. Simple break. Maybe some of you have had a broken arm or a broken leg, and this would be a closed or simple fracture. Then there's the open or compound fracture, and that is actually where fragments of the bone break through the skin. So open fractures have 3 grades of severity. Grade 1 is the least severe injury with minimal skin damage. So the bone has broken through the skin, but the skin has minimal damage. Grade 2, moderately severe injury with skin and muscle contusion. So you've got some bleeding, internal bleeding, and some injury of the muscle. Grade 3 is the most severe, where you have a wound larger than 6 to 8 centimeters with skin, muscle, blood vessel, and nerve damage. So you can see that's the most severe because it has the nerve damage involvement. Then we have a stress fracture, which is caused by either repeated or prolonged stress. Pathologic fracture occurs because of a pathologic condition in the bone, like maybe a tumor that causes spontaneous break, like osteoporosis can be a condition. It's not a tumor, but it is a condition. Also, maybe osteosarcoma, a tumor in the bone. So cause and risk factors. Commonly caused by trauma to the bone, so that's the normal type of trauma that causes a fracture, and usually as a result of an automobile accident, motorcycle accident, or a fall. Bone disease or bone cancer can also lead to a fracture. Hip fractures in older adults usually are from falls. Risk factors from hip fractures, osteoporosis, advanced age, white race, use of psychotropic drugs, and female. And while I'm talking about drugs, I want to mention that there's certain other drugs that can cause fractures as well, and that's steroids. When you're on steroids or glucocorticoids, they do make the bones softer and they're not as strong. Also cyclosporin, methotrexate, heparin, anticonvulsants. So in adults, ribs are the most commonly fractured. Now remember, yeah, a rib fracture isn't that bad, but a rib fracture can cause a lung puncture. So it can lead to further damage. Fractures of the femur is the most common in young and middle-aged adults. Hip and wrist fractures are most common in older adults. And the reason that is because older adults or the elderly tend to fall due to osteoporosis, or they trip over something. Their eyesight isn't so good and their balance isn't so good. So they might fall and they try to catch themselves when they fall. And if they fall forward, they'll fall on their hands and their wrist will fracture because it too has osteoporosis. The number of hospital admissions for hip fractures of people 65 and older was 258,000 as reported in 2010. So a lot of money is spent on fractures. And not only fractures like hip fractures, but also what leads to being confined to the bed with a hip fracture. Well, skin breakdown or even pneumonia. So sometimes even more money is spent related to the problems that go along with fractures. So these are the healing stages of fractures. And if you've got your book with you, there is a picture on page 881 of these different healing stages. The first one is hematoma formation. Stage 2 is fibrocartilage formation. 3 is pretty important. This is the callus formation. This is where it starts to knead together. So this is stage 3. It's forming a callus and beginning to turn into a bone, which is stage 4, where it actually ossifies or hardens. And then stage 5 is consolidation and remodeling. So in the absence of bone disease, most older adults eventually heal as well as young adults. So here's just a picture of the same one that's in your book, different pictures of how it looks as the healing process proceeds. So you've got the hematoma, and you can see the compound fracture, and then the hematoma to granulation tissue, which begins to bring the bone together. The callus formation, stage 3, it's an important stage. And then the osteoblastic proliferation, where the osteoblasts begin to grow together to form the bone sealing, the bone remodeling, and then the bone healing is complete. And you can see there's a lump there for a while until then it does totally heal. So what are the complications of fracture? So the first one I'm going to talk about is infection or osteomyelitis. I'm going to go into detail on each one of these after I'm done just going through the list. So fat embolism, that's going to be an important one we're going to talk about. Deep vein thrombosis or DVT. Compartment syndrome is a unique condition we're going to talk about. Shock, joint stiffness and contractures, which can be a result after a fracture. Malunion, non-union, and delayed union. I'm going to tell you a little story about that one. Post-traumatic arthritis. So after the injury has healed, the patient is left with an arthritic limb. Avascular necrosis can be a very significant problem. As you can tell, avascular without vascular, without blood to the tissue, and then it necroses. Complex regional pain syndrome, that's a unique condition I'll talk about when we get to that. So the first one we'll talk about is the osteomyelitis, and that's caused from contamination of the open wound that's associated with a fracture, or from contamination of indwelling hardware used to repair the broken bone. So some bones are held together with wires, nails, other kind of metal plates. When the infection is inadvertently brought by surgery or other treatment, it is known as iatrogenic. So it's caused by something else. Any infection can interfere with normal healing. Osteomyelitis is common after an open fracture because dirt gets into the wound, and then that dirt can also affect the bone, the ends of the bone, and they get infected. Bones are very difficult to get rid of infection, or osteomyelitis is difficult to heal because there isn't much blood supply to the bone. So the antibiotics have a difficult time getting into the bone. Also surgical repair, and it may become a chronic infection. In deep, grossly contaminated wounds, gas gangrene may develop. So signs and symptoms: local pain, redness, purulent wound drainage, chills and fever. With gas gangrene, there's foul-smelling, watery drainage with significant redness and swelling. The treatment for the osteomyelitis is IV antibiotics that can be given from 4 to 8 weeks, followed by 4 to 8 weeks of oral drug therapy. So you can see it's a long time for osteomyelitis. Wound care would be irrigation with normal saline or even an antibiotic, treatment with antibiotic beads, and surgical removal of dead bone tissue and or hardware. Get rid of the bad, dirty, dead bone tissue and allow the new tissue to grow. Fat embolism. Now, fat embolism can be released from, or fat globules can be released from the marrow of a broken bone, and it goes into the bloodstream and then migrates to the lungs. Now, this is an embolism, so it is a fat clot, so it's made out of fat. It's opposed to a pulmonary embolus of a blood clot. So they lodge in capillaries and obstruct the blood flow. The fat particles break down into fatty acids, which inflame the pulmonary blood vessels, and that leads to pulmonary edema. So you don't need a blood thinner because this is fat, and the fat will soon break down into fatty acids, but the side effect of that is it causes inflammation in the blood vessels, and it can lead to pulmonary edema or fluid in the lungs. So that's common with fractures of the long bones, especially multiple fractures and severe trauma. Symptoms would be confusion, restlessness, because they're not getting good oxygenation. Another unique symptom and sign for fat embolism is petechiae on the arms, chest, and abdomen. So you've got the shortness of breath, the confusion, the restlessness, and the petechiae, and a fracture. That will all point to a fat embolism. And remember, petechiae is like a little rash. It looks like red dots on the arms, chest, or abdomen. So DVT, venous stasis, vessel damage, and altered clotting mechanisms contribute to formation of blood clots or thrombi, and they're most commonly in veins of the legs. So a fracture may lead to bed rest, and then because of the venous stasis caused from the bed rest, the clotting mechanisms could form a blood clot in the calf of the leg, the deep vein of the leg. The DVT is increased with immobility, often associated with a fracture. Thrombi can break off and travel to the lungs, causing a pulmonary embolism. Now, this is a clot, so this is B1, where the patient would be put on a blood thinner, and that clot would have to break down or dissolve. Signs and symptoms of a pulmonary embolus. Respiratory distress is the first sign. Oh, I have this of a fat embolism. Well, it is that too. Followed by tachycardia, tachypnea, fever, confusion, and decreased level of consciousness. The treatment is bed rest, gentle handling of the limb, fracture, oxygen, ventilatory support may be needed, fluid restriction, and diuretics for pulmonary edema. Compartment syndrome. So compartment syndrome is a unique situation, a serious complication from internal or external pressure on an affected area. Compartments are enclosed spaces made of muscle, bone, nerves, blood vessels, and they're wrapped by fibrous membrane. Internal pressure from bleeding edema into a compartment causes external pressure from a cast or tight dressing. So I'm going to give you an example so you can kind of see what a compartment syndrome would be like. So if you take your hand and make like an L with your index finger and your thumb, so that tissue that's right in between is like a compartment. And if you feel, it's surrounded by bone and muscle. So let's say you got a fracture or a bite in that area, it can't go anywhere. So it just swells up and begins to put pressure on the blood vessels and the nerves, and it can create quite an emergency type of a problem. When it talks about being caused from a cast, that can be because the bleeding or edema has made such a tight area under the cast that they can get a compartment syndrome from that. So when bleeding or edema into a compartment, there's nowhere for the drainage to go. It's trapped in a space. Increased fluid puts pressure on the tissues, nerves, and blood vessels so that blood flow is decreased. And that results in severe pain and tissue damage. External pressure also can decrease blood flow to the area. So that's a cast being the external pressure. The primary symptom is pain, and this is very severe pain. In fact, it can't be relieved with opioids. So that's one of the uniqueness of a compartment syndrome. It is pain unrelieved with opioids. It's especially painful with touch or movement. Other signs and symptoms are edema, pallor, weak or unequal pulses because of decreased blood flow, cyanosis, again decreased blood flow, oxygenated blood getting to the area, tingling and numbness because and paresthesias because nerves are involved, and finally severe pain. The goal of treatment is to relieve the pressure. When internal pressure is involved, a surgical fasciotomy is made by the doctor where linear incisions are made into the fascia that relieves pressure on the nerves and blood vessels. And for the external pressure, the cast or dressings may have to be replaced. So shock can occur after a fracture because there's a risk of excessive blood loss, especially if it's a compound fracture, or any time blood leaves the blood system and goes into the tissues, it's blood loss. Trauma may rupture local blood vessels. Internal organs may be punctured, like in a pelvic fracture. Pelvic fracture can puncture the bladder, and I had mentioned how a rib fracture can puncture a lung. And this can result in internal bleeding or rupture of the organ. Loss of blood leads to shock, evidenced by tachycardia. So it's important that you remember these signs and symptoms of shock. It is going to keep coming up, and this shock is related to hypovolemia or bleeding, and the patient has tachycardia, anxiety. Whenever a patient is anxious or restless, something's wrong, especially if it's out of character for that person. Pallor and cool, clammy skin. Also, they'll probably have hypotension that goes along with that tachycardia, and their respirations will speed up trying to get more oxygen into the body. Immobilizing fractures reduces risk of hemorrhage. If severe external bleeding, external pressure should be applied and medical assistance summoned immediately. So we talked about emergency situations, and bleeding was one of them. And we know that pressure on a bleed should be applied. And once you've applied pressure, don't remove that pressure. Keep the pressure on. If you have to keep applying pressure, more towels, more sweaters, more blankets, whatever, keep applying them. Don't take them off, because then that will allow that area to bleed, external bleed. Joint stiffness and contractures. So joint fractures or dislocations can be followed by stiffness or contractures, especially in older adults, because they don't want to move. It hurts to move. So they kind of stay in one position, and they hold their arm in one position or their leg in one position. And that can lead to joint stiffness and even a contracture. To prevent requires appropriate positioning and progressive exercise program. So changing the position, if you have to elevate an arm or a leg for swelling of a fracture, that's fine, but they should be moved around. A range of motion should be done, whether it be passive or active range of motion in the joint area to prevent contractures. Treatment may include splints, traction, casts, surgical manipulation, and aggressive physical therapy. So avascular necrosis. Now let's remember what that word means. A is always without, so without vascular, and it becomes necrotic. It begins to die. So a variety of factors can interfere with the blood supply after a bone injury. Once bone cells are deprived of oxygen and nutrients, they die, and their cell walls collapse. The signs and symptoms would be pain, instability, and decreased function in the affected area. I had a friend who fell when she was in another country, and she didn't want to be taken care of in that other country. So she had fractured her hip, but she had to wait for a helicopter to come and take her to the United States. And by the time she got there, she had some avascular necrosis. So she has had 3 surgeries on that hip trying to clean out the dead tissue. So it can be a long-term problem. Complex regional pain syndrome. So this is a unique condition where the patient feels pain, but the doctor doesn't know where it's coming from. So there's no nerve damage, there's no edema, no muscle spasm, contractures, vasospasm. They might have sweating, some atrophy, contracture, and they're going to lose bone mass because they can't move. They don't want to move. They're just in too much pain. Treatment would be nerve blocks, physical therapy, but they're in so much pain, they don't even want people to touch them. TENS unit may stimulate the area to be able to move easier. Anti-seizure meds, antidepressants, because it's very depressing to have this situation. Signs and symptoms of fractures. So we're kind of going back to the beginning. Depends on the type and location of the break, what your signs and symptoms will be. Some fractures have so few manifestations that they can be detected only with X-ray. So that's happened to some people where they fall and hurt their ankle, and they limp around, and their ankle gets swollen, but they don't think it's broken. They just think maybe it's sprained. So they hobble around, and then maybe it just doesn't get better. So they go to the doctor and they have an X-ray, and lo and behold, there's a fracture. Signs and symptoms: swelling, bruising, pain, tenderness, loss of normal function. Abnormal position. Well, if there's an abnormal position after a fall, you know it's probably broken, right? Decreased mobility. So if you'll see box 45.1 on page 883, it says signs and symptoms of fractures and their causes. So that goes through all the things that we were talking about. One extra thing it talks about is crepitus, and crepitus results from broken bone ends rubbing together. It can also be like air getting into that area, especially with a compound fracture. Crepitus is the sound of like bubble wrap. When you pinch bubble wrap, the noise that it makes, that's what crepitus sounds like. So it's actually a sound. So some diagnostic tests and procedures would be just standard x-rays can see bones really well, and they can see a break. Maybe a CT scan if you want to see a more linear or smaller break. MRIs are very sensitive to soft tissue damage, so MRIs are good for that. And then a bone scan can always see, let's say that there's a tumor. It might see that really well, and that involves dye. So medical treatment can be reduction of the fracture or a fixation of the fracture so that it doesn't move, and that could be with a plate or screws. Effective pain management of a fracture is essential for patient mobilization and healing. External fixation allows for early ambulation and mobility while relieving pain. So this is an example of a closed reduction. So they actually give the patient some pain medication and they reduce the fracture, or they put make the alignment right externally. So they use their hands to put it into alignment. And then they would put a cast on that to make it stay in alignment. Internal fixation devices, you can see the plates and the wires, the screws that are involved in an internal fixation. Now this is an external fixation where they've put the screws that stick outside of the body, and those are all held together with other type of metal rods. Now doing a dressing change on an external fixation is very involved. You need to clean each little area where the rod goes into the skin that goes into the bone, because anytime you have something going from the outside of the body to the inside of the body, it's a place where it can bring infection, and we don't want any osteomyelitis secondary to this external fixation. So the pins align the bone, and then we do dressing changes, maybe antibiotics, maybe wet saline. When extensive soft tissue damage or infection occurs, external fixation allows easier access to the site and facilitates wound care. So be sure that you recognize signs and symptoms of infection would be redness, swelling, purulent drainage. And you might have a fever, and your white count might be elevated because your body's trying to fight off the infection. So some therapeutic measures that are done after a fracture, casts, splints, and immobilizers. So to prevent swelling, a patient who is wearing an arm cast should keep the arm elevated above the heart when lying in bed. So a pillow to elevate the arm or pillows to elevate the legs is good. But remember, you want to move those pillows from time to time so that you don't get a contracture secondary to keeping the arm or leg in a fixed position. Traction can be used to keep alignment. Electrical stimulation and pulsed electromagnetic fields. And also some crutches, walkers, or canes can be used to help the patient get around. So let's talk about the different types of traction. So Buck's traction is actually a skin traction. And it's these pads that fit onto the leg. And then notice that they're held on by pulleys. And these weights or pulleys must swing freely. And if you'll see in each one of these pictures, the weights are swinging. They're not touching the ground. Because if they touch the ground, then you lose the traction. So it's very important to remember that the weights must swing freely. And then notice Russell traction is similar to Buck's, but it's not skin traction. It is just the leg is elevated and pulled with the pulleys. And then you've got the pelvic traction, where the traction is pulling from the hips. Quite contraptions, huh? Electrical stimulation. So electrical stimulation is used to promote bone healing by promoting bone growth. And it's successful in 80% of cases. The purpose of this stimulation is to regenerate cells and promote healing. It also reduces pain. But let me tell you a little story. So my brother was in a car accident back in the Midwest, and they have these big tractors with the big pointy thing, I forget what it's called, and that tore off the whole side of his car. It did break his humerus, but luckily he did have some, not luckily he had rib fractures, but he had rib fractures, but no lung puncture. So because the humerus is one of the bones in the body that can heal itself, they really didn't set it. They didn't connect it, and it was broken. There was about a 2-inch separation between the two bones. So what they did was they set him up with electrical stimulation, because that was to promote the bone healing and connecting of the bones, because the humerus was supposed to do that anyway. But he was one of those 20% where it wasn't successful. So he actually had to have surgery, and he had plates put into his arm to fix that humerus break. So it doesn't always work. So crutches is a way to get around with a fracture. And you must remember that there's 3 to 4 finger breadths, or if you notice in the picture, there's 3 fingers between the armpits and the crutch. So that's pretty important to remember. Now this is the tripod position. This is the position where you can see where the feet are next to each other and then where the crutches are. And it forms a tripod. So the crutches are out to the side a little bit in front of the feet. And there's a non-weight bearing foot, or the affected foot, so that would have the fracture. And then the weight bearing foot, which is your good foot or the non-fractured foot. So you would use the crutches to help balance you, and that's why they're out a little bit further than the feet. So the tripod position. Let's try a question. So open fractures are graded by severity. Which grade is a moderately severe injury with skin and muscle contusions? So the answer is B, grade 2. Open fractures have 3 grades of severity. Grade 1 is least severe with minimal skin damage. Grade 2, moderately severe. With skin and muscle contusions. Another question. Fracture healing occurs in stages. Which stage is described in the following statement? Within 3 weeks to 6 months after the break, a permanent bone callus, known as woven bone, forms. It is during this stage that the ends of the broken bone begin to knit. So the answer is D, stage 4. So a bone begins to heal as soon as an injury occurs. New bone tissue is formed to repair the fracture, resulting in a sturdy union between the broken ends of the bone. Healing occurs in the following 5 stages. So, what are the different kinds of assessment after a fracture? So I want to turn to that page, and that is page 890, focused assessment. So focused assessment, this is nursing care of the patient with a fracture. So even after the initial medical care has been given and the fracture has been set, you still need to find out the extent of the injury and any complications that may go along with that. You want to document the number and types of prescription and over-the-counter medications taken by the patient. And it's helpful to find out about other medical problems that the patient may have, like diabetes or any heart conditions. And you want to determine the patient's occupation. Is this going to hurt their work? Are they going to be able to work after they've healed? So we want to determine the patient's occupation and usual roles and responsibilities, and discuss with the patient and family the effects of the injury on their usual activities. And maybe they need some home health to help them continue to get a little bit stronger. We want to do a physical exam. We want to compare extremities, look at the one that's not injured and compare it with the injured. We want to check for the color, the temperature. We want to check for touch. We want to check for circulation. And additional problems would be nutrition, inadequate nutrition. We want to be sure they get eating correctly so that they can heal, right? And we know that vitamin C is good and zinc is good for healing. So what are some interventions that we're going to have to use? Well, pain, they have pain, so we're going to need to give them pain medication and pain relief. We might need to reposition them in bed with pillows and help them turn from side to side. Also inadequate peripheral circulation. So we need to do frequent neurovascular checks and determine whether circulation is adequate and detect signs of pressure on the nerves. So we want to constantly be checking pulses, circulation, warmth, coolness, cap refill, anything involved with the circulation. And then there's always a potential for infection. If there was disruption of the skin with the fracture, of course, that's an opening in the skin. If they had to have surgery, opening in the skin, they're at risk for infection. We want to always do aseptic technique in any dressing changes or wound irrigations, and care for pins and drains. Observe the pin sites, as I had said before, for any signs and symptoms of infection. Immobility. Well, there's risk for immobility, isn't there? And the complications would be DVT, which we've talked about, pulmonary embolism, contractures is a complication of immobility because they just don't want to move. So then that shoulder, let's say it's an arm, that shoulder gets a contracture because they haven't done range of motion and they just haven't wanted to move it because it hurts. And some people won't even take pain medication. So they just try to tough it out. So that leads to even further immobility. Another thing that can happen is GI problems. So constipation, not only from their immobility, but because also the pain medications that they may be taking, the opioids, can lead to constipation. So that's always a problem with immobility. So we always want to encourage our patients to try to do range of motion and wiggle their fingers, wiggle their toes. We want to get gait training, and get them up as soon as possible. Prevent skin breakdown, because if they're just sitting in one place, that can cause breakdown, and they can have a potential for skin breakdown, right, from not moving. And also, we want to have a activity, get them up out of bed, walking around, ambulate, and rest in between their activities. We want to teach them, and that should take place right away, how to get up, how to take care of themselves, how to assess their own injury, to watch for problems or infection. And if they need any kind of assistive devices when they go home, maybe they need a potty that's raised up if they had a hip fracture, or maybe they need handlebars put in places so they can help move around. So let's talk about a hip fracture specifically. So by 90 years of age, 17% of men and more than 30% of women have sustained a hip fracture. Most hip fractures are in the femoral neck and intertrochanteric region. So when you take care of a hip fracture patient, be sure you know what kind of a hip fracture it was and what kind of surgery was done on that hip fracture. So medical treatment would be internal fixation, a femoral head replacement, or a total hip replacement. So see what I mean? There's 3 different kinds of surgeries a patient could have for a hip fracture. So just saying your patient has a hip fracture doesn't really tell me everything, does it? All right. So you can see a picture on page 894 of the different types of fractures: the neck fracture, the intertrochanteric fracture. Post-op, these patients may begin physical therapy as early as 1 day after surgery. So we want to take care of that. Hip fracture, continuing on with interventions, they're geared towards relieving pain, promoting mobility and independence, and prevention of complications. Again, the post-op patients may begin physical therapy as early as 1 day after surgery. Definitely, we're going to get them out of bed. But there's always rules, whether you can put weight on that hip. Can they lay on that hip? So be sure you check your doctor's orders for specific directions about that patient's hip fracture and surgery. You can turn the patients from side to side unless the doctor says don't lay them on that surgical side. The affected hip must not be adducted or flexed more than 90 degrees because excessive flexion can dislocate the prosthesis. That's important to remember. Now, what's a Colles fracture? Well, a Colles fracture is the wrist, and this begins on page 895, Colles fracture. It's a break in the distal radius. Colles fracture often occur in older adults, particularly older women, when an outstretched hand is used to break a fall. Signs and symptoms are pain and swelling in the area of the injury, and a characteristic displacement of the bone in which the wrist has the appearance of a dinner fork. So medical treatment would be managed by closed reduction or manipulation of the bone and immobilization in either a splint or a cast. The elbow is immobilized as well to prevent misalignment. So remember how important alignment is in fractures. That's one of the reasons for the traction also, is to keep the alignment of the bone. Okay, let's see what's next. So more on the Colles fracture. We want to assess their pain and swelling following the treatment of the fracture. Always, again, checking can they wiggle their fingers? Do they have feeling in their fingers? Do they have good cap refill? So the extremities should be supported and protected and can be elevated on a pillow during the first few days. Any longer than that, they can get a contracture. Encourage patients to move their fingers and thumb to promote circulation, reduce swelling, and to move their shoulders to prevent stiffness and contracture. So they can just up, down of their shoulders, and also rotate their shoulders around. We also want to teach proper cast care. Now remember, along with having them move their fingers and thumb to promote circulation, we also want to check their cap refill and the temperature of their fingers to be sure that they're getting good circulation. Pelvic fracture. Now that begins on page 896. Pelvic fracture. They can account for a small percentage of total fractures. They're the second leading cause of death from trauma after head injury. As with other fractures, the diagnosis and severity of the injury are confirmed by radiograph. So a pelvic fracture can be just a crack, or it can actually be a total break in the pelvic bone. The treatment depends on the severity of the fracture. It can be a non-displaced fracture, and that's just treated with bed rest on a firm mattress for a few days to 6 weeks. A more severe fracture may require one or more of the following: a pelvic sling in the traction, skeletal traction, a double hip spica cast, or external fixation. I believe you have some good pictures of casts on page, let me find that page for you. That is page, where is that? Sorry, on page 886. So there's your short arm cast, a long arm cast, a body jacket cast, and then the spica cast. So you can take a look at that. Table 45.1. So nursing care, you want to do a focused assessment, and remember talking about a fat embolism. When you've got a pelvic fracture, they are at risk for a fat embolism, bleeding, swelling, infection, thromboembolism, and pain. Also, a fractured pelvis can puncture the bladder, so they can have injury to the bladder. So we want to closely monitor the patient for specific injuries, check the presence of blood in the urine and stool, and assess the abdomen for any signs of rigidity or swelling. Assess urine output, because the absence of urine may indicate a perforated bladder. So other interventions are designed to alleviate pain and promote mobility, preventing complications. And remember, with any of these long-term fractures, pneumonia would be a secondary problem. So we always want to have them cough and deep breathe and move around as soon as possible. Take extreme care to prevent displacement or of fracture fragments if there is a fragmented fracture. Have the patient pull up on trapeze. So this is a perfect time to have a trapeze over the bed so the patient can lift their bottom off of the bed. You can change linen. You can put them on the bedpan. And that helps also. It builds a little self-confidence because they're able to help themselves even though they're helpless in the bed, but at least they can help turn or they can pull themselves up on the trapeze. It's important for you to always have the patient help as much as possible because it does help build their self-esteem and they feel like they're helping themselves get better. So interventions, assess urine output. Oh my, I'm saying that a couple times. It must be pretty important because the absence of urine may indicate a perforated bladder. Extremities should be supported and protected and can be elevated on a pillow during the first few days. So why only the first few days? Because we don't want a contracture in the hip area. Encourage patients to move their fingers and thumb to promote circulation and reduce swelling. So I have fingers and thumb here under pelvic fracture, but that's kind of funny, isn't it? Wiggle their toes and teach proper cast care.